Good evening, ladies and gentlemen. I am Dr. Manivasagam, current president of Indian Academy of Echocardiography. It gives me great pleasure to welcome you all to this special webinar. Under the visionary leadership and initiative of Dr. S.K. Parashar, we have consistently organizing collaborative webinars with several reputed and eminent echocardiography societies from around the world. This month, we are delighted to host a joint session with the Bulgarian Society of Echocardiography. I extend a warm welcome to Professor Ristova, President of Bulgarian Society of Echocardiography, and her esteemed team. Let me now outline the protocol for today's session. The session will begin with opening remarks and a case presentation by Professor Ristova. This will be followed by presentation from Dr. Ladova. Next, from our side, Dr. S. Shanmu Sundaram will present his case. After that, he will continue with alternate case presentation from both the teams. Total duration of each presentation will be 10 minutes, and we will conclude with question and answer session, where we will address questions from the chat box. Now it is high time for me to introduce Rasimira Histova. She is a current president of Bulgarian Society of Echocardiography, associate professor of cardiology, University National Heart Hospital, Department of Non-Invasive Functional Diagnostic and Imaging, head of outpatient clinic. With that, I now hand over the session to Professor Ristova. The floor is yours, madam.
Thank you very much, dear colleague. I just want to share my screen. You can see my screen now?
Yes, definitely.
Before to start my presentation, I would like to thank you all organizing committee, especially Professor Parashar, for the kind invitation to be here with all Indian Academy of Echocardiography to present this very interesting session focused of the hypertrophic cardiomyopathy. This is one of the last very famous topics that even European Society of Echocardiography and American Society of Echocardiography was focused the last many of the session during the their clinical presentation. So I will give it a little bit very short update about the hypertrophic cardiomyopathy. What is the mechanism to analyze and to give the prognosis and update of the management of these patients, because the hypertrophic cardiomyopathy is a genetic disorders of the heart muscles, and is characterized with very small ventricle cavity and marked hypertrophy of the myocardium and myocyte disease. This caused the primary mutation of the sarcomere proteins and could be also inherited with very autosomal dominant manner of different cases. So I am starting with one clinical case that it's coming in our clinic. This is the 66-year-old male with multiple episodes of elevated low-level troponin and chest pain, which is referred to cardiology clinic. His ECG and transthoracic echocardiography was taken and shown like below. We even performed the speckle tracking echocardiography with very poor ejection fraction, and the global longitudinal strain is very low level. What is we could see here in our ECG, this is the marked sign of the left ventricle hypertrophy. When we look at about the discrepancy of this disease, we can show that epidemiologically, all around the world is we could find different type of the hypertrophic heart. This is the one of the study which was published in 2022. Included 125 countries, around 90% of the world population, and the prevalence of the hypertrophic cardiomyopathy is 1 to 200 to 1 to 500. That means that around 15 to 20 million of the people around the world are affected with the hypertrophic cardiomyopathy. The gap of the diagnosis is the mainly because under utilization of the cardiac imaging, some of the diagnosis is missed, and there is also the lack of the widespread expertise during the examination of the patient. Last year's American Society of Cardiology and European Society for Cardiology, they proposed a couple of the pathway journeys about the screening of the patient with the hypertrophic cardiomyopathy. The mainly individual suffering from the symptoms seek the people who seek the treatment, more or less around 40%, they the first initially visit is with the cardiologist, which is starting for the performing the ECG, and then the Holter monitoring and stress echocardiography. We could also refer it from the different specialists to perform the echocardiography and cardiac MRI. Patient will be successfully diagnosed with the hypertrophic cardiomyopathy. But there is around 33% of the people that could be not find the right way, and only this 33% of the patient could be understood that they have the hypertrophic cardiomyopathy disease. This is the number of the patient that could be not very well treated during the journey. From the first time when we have the symptoms to diagnosis, this patient could be have a little bit long way for the diagnosis of the hypertrophic cardiomyopathy, and more or less this could be around 5 years from the initial symptoms. So this diagnosis of the symptoms of the chest pain, systolic murmur, palpitation, dizziness, passing out, the family history from the unexplained passing out, this could be one of the signs that the patient maybe could have some presentation of the hypertrophic cardiomyopathy with additional abnormalities, even of the ECG. But showed the clinical data that many of the patients, around 90% of the patients with the hypertrophic cardiomyopathy, they have abnormal ECG. We could perform it with some of the co-waves, ST depression, or left ventricle criteria from left ventricle criteria hypertrophy could be presented, or even for the LBB or RBB could be also have from the some of the type of the hypertrophic cardiomyopathy patients. When we look at about only from the ECG, and we have doped the echocardiography played the main diagnostic role from this kind of the patient. When we look at about the maximal end-diastolic wall thickness, more than 15 millimeter, anywhere in the left ventricle, and the absence of the another cause of the hypertrophy, like the athletic heart or hypertension or aortic stenosis, we could be very sure that this diagnosis must be hypertrophic cardiomyopathy. Then we must analyze it. Is the different type of the hypertrophic will be hypertrophic, apical hypertrophy, or reverse curve or sigmoidal hypertrophy of the septal, which is not non-obstructive variant, or obstructive cardiomyopathy with obstruction of the left ventricle outflow tract obstruction, or aneurysm of the apical aneurysm with the obstruction of the middle part of the heart, when you look at in these pictures. The latent obstructive right ventricle hypertrophic cardiomyopathy, this is obstruction during the provocation with the different type of the maneuver that we could perform during the diagnosis of the patient. So this is the one of the patient of our clinic. He comes with again with some dizziness and chest pain performed. Actually, this is the patient who is on the treatment with the mevacamtan. Here is another patient with the gradient of the outflow tract around 60 millimeter in the rest. Here is with the very poor speckle tracking imaging, which show the diffuse hypertrophy of this patient. So we can have this different type of the hypertrophic cardiomyopathy, basal septal hypertrophic cardiomyopathy with the selected images of the echo, concentric hypertrophic cardiomyopathy, reverse hypertrophic cardiomyopathy, and apical form of the hypertrophic cardiomyopathy. The stress echocardiography is one of the main type of the analysis which we could perform it with the patient of the hypertrophic cardiomyopathy, especially when we have this obstruction, and we could present with the physically test for stress test or with very low dose of the dobutamine. But we look at about during the stress test, this is the mainly to increasing the gradient of the outflow tract, which is the most important for the patient. And this could be also the obstruction of the outflow tract is the one of the sign that patient could be with the very high level of the sudden cardiac death of the during the life. So many of the echocardiographic studies they describe it as obstruction of the left ventricle outflow tract was initially to be caused solely by the encroachment of the hypertrophic basal septum into the left ventricle outflow tract during the systole. How we can measure this during the patient when we have some mitral regurgitation, because one of the very difficult types when we have this mitral regurgitation, the peak velocity gradient could be diminished with the jet of the mitral regurgitation. But when we look at about the signal of the mitral regurgitation, the signal could be very circle, and also the could be late after the will becoming the signal from the became the signal from the left ventricle outflow tract. Also, distortion of the mitral leaflets frequently result in the secondary mitral regurgitation, which will be the major cause of the severity of the symptom of the heart failure. We can very often see it in the patient with the left ventricle hypertrophy and hypertrophic obstructive cardiomyopathy. The mitral regurgitation could be presented with this very late systolic event, usually directed posterolaterally, and it's very the severity depends on the degree of the outflow tract obstruction. If we have this very visible left ventricle outflow signal tract, but sometimes we have very good mitral regurgitation signal. We just it's possible to calculate the pressure of the outflow tract when we have only three steps to use during our practice. We must know the systolic blood pressure. We must know the left atrial pressure, which it's could be around the 15 or 7 millimeter per mercury. The first step, this is the measure the mitral regurgitation velocity to calculate this left ventricle left atrium pressure distance when we have this around 7 meter per second is around, could be around 200 millimeter per mercury. The second, when we know the left ventricle atrial pressure to get to the left ventricle pressure, we will add this pressure and it's become around 225 millimeter mercury. And the third step, this is the subtract the systolic blood pressure from the left ventricle pressure, and we will receive the data from the outflow velocity gradient around 122 millimeter mercury. It's very easy. It's not very common, but this is one of the possibilities to be very clear when we want to analyze this obstruction in the left ventricle outflow tract. So looking about the hypertrophic obstructive cardiomyopathy, there is different phenotypes which could be analyzed with the genetic analysis. And also the genetic heterogeneity is the most important for to differentiate the different type of the phenotype of the hypertrophy. We could have this atypical distribution of the hypertrophy. We could have the non-obstructive hypertrophic cardiomyopathy and obstructive cardiomyopathy without hypertrophy. It's also possible with the phenotype of this type of the obstruction. This is the one of the recommendation from the initial clinical evaluation of testing algorithm, the patient with the suspecting to have the hypertrophic cardiomyopathy. The first physical exam and collected the personal history of the disease and the symptoms, also the family history for the hypertrophic cardiomyopathy or for the sudden cardiac disease, the main that we must present for our patient. ECG, echocardiography, cardiac MRI is the most important to indicate the type of the hypertrophic cardiomyopathy and to phenotype the left ventricle hypertrophy. Then to describe the hypertrophic cardiomyopathy with the treatable condition which will be compatible for the normal life expectancy of the patient. Then we have the obstruction of the rest. We must test this patient for the provocation with a different maneuver or with the stress test, or if we don't have the non-obstructive cardiomyopathy, we must perform it with the stress echo. Genetic testing, it's very important, especially when we have this different type of the pathogenetic mutation, and to differentiate what of type of the family it's injured from the disease or not, on the surveillance from the left ventricle development hypertrophy. Do we measure the left ventricle wall thickness accurately? This is the one of the problems that we could meet in our practice with the very high inter-observer variability in the measurement of the myocardial wall thickness. It's very important. Less reliable for the hypertrophic increasing. We must avoid right ventricle and also the structures of the left ventricle like muscles, and which could be performed with the could be cause over measurements. Also, when we look at about this type of high variability of the maximal wall thickness with the different correlates with different biomarkers for the hypertrophic cardiomyopathy, could send the patient from the cardiac MRI or the CT of the heart. This is very important because with the simulation of size of the mitral myocardial wall thickness variability could be described the best algorithm from the ICD decision on for the patient who will be potentially impacted from the ICD treatment. One of the problems that we could avoid during the measurement of the diameter of the myocardium, this is the thickness of the myocardium from the middle of the short axis level. This is the possibilities for the overestimated the wall thickness because we can measure together with the crista supraventricularis and where its crista is hypertrophic. But when we look at it from the cardiac MRI or from the CT, this could be one of the methods that we could improve the measurement of the left heart. The cardiac MRI is one of the methods that we could use it during the diagnosis of the different type of the hypertrophic cardiomyopathy because the echocardiography, we have some limitation to visualize the better way for the apex or for the some of the septal part or the lateral part of the wall or for the right ventricle when we look at about these different type of the hypertrophic cardiomyopathy. So around 10 to 15% of the patient, they had only focal hypertrophy, and this could be also not visible every time on the echo. Which is the echo-blind areas that we could have like idea. This is the apical part mainly, the deep crest, asymmetric lateral wall could be also one other possibilities to not underestimate during the echo, and interseptal hypertrophy could be also possible to diminish during the echocardiography. Multimodality imaging is one of the mainly recommendation for we have the patient with this clinical suspicion for the cardiomyopathy using echocardiography and cardiac MRI for assessing the left ventricle function, hypertrophy, dilatation, using cardiac MRI for possibilities for the tissue characterization, using for the leg linear enhancement for the T1, T2, T22, also for diagnosis of the cardiomyopathy, phenotype identification, and for the different phenocopies. Multimodality imaging also have the possibilities for the functional abnormalities when we can use the stress echocardiography for valvular and dynamic gradients assessment and stratification for the risk and prognostication. Also for the analysis of the myocardial ischemia and differentiate the different target study for the like the screening for the amyloidosis and the myocardial inflammation, it's also possible. This is the one of my last slides, that role of the artificial intelligence in the hypertrophic cardiomyopathy. There is different studies published in the couple of 2-3 years that deep learning and echo work can automate measure the wall thickness evaluation and facilitate the identification of the hypertrophic cardiomyopathy, especially in the patient with the cardiac amyloidosis. Also the using of the artificial intelligence in the cardiac MRI of perfusing imaging. It's also one of the most important possibilities to analyze the diagnosis and to have the very good resolution about the diagnosis with the sensitivity and specificity about 90%. The presence and the absence of the symptoms of obstruction dictate how we can measure the strategy for the patient with the hypertrophic cardiomyopathy. If we have the patient with the obstructive cardiomyopathy or non-obstructive cardiomyopathy, the symptoms and the gradient of the left ventricle outflow tract more than 30 millimeter mercury of the rest with the provocation or negative inotropic treatment with the beta blockers, calcium channel blockers, good hydration, and possibilities for using therapy for the cardiac myosin inhibitors. This is the new treatment for the hypertrophic cardiomyopathy, or to send the patient for the septal myectomy or alcohol septal ablation, or myotomy of the septal reduction therapy. Mavacamten, this is the new molecule, and there is a couple of new molecules about myosin inhibitors that was performed in the last couple of years with the good result about the patient with the hypertrophic cardiomyopathy with obstruction of the left ventricle outflow tract. The results are very promising. The guidelines, even the European, they was proposed the mavacamten like class 2A for the patient from symptomatic hypertrophic cardiomyopathy and some septal reduction of therapy like class 1 of the therapy. So like the summary, the patient with the hypertrophic cardiomyopathy could present with the diagnostic challenges in nowadays. The cardiac imaging remains the mainly for the diagnosis of the patient with the hypertrophic cardiomyopathy. More than 15 millimeters of the thickness of the wall of the left ventricle by echo or the cardiac MRI is most important. 90% of the patient will have the normal ECG, findings future help with the disease detection, and artificial intelligence could improve the clinical workflow efficiency, but also improve the disease detection. And this could be a guide for that we need for expert of the care of the patient with the hypertrophic cardiomyopathy. Thank you. It's my pleasure to invite one of Bulgarian.
We'll have the question and answer at the last session. Next, you request your teammate, that is Dr. Martina, to proceed with their presentation.
That she will advise, yes.
Oh, okay. Do you hear me now? I think I mute. I'll share my screen. Okay. Okay, do you see my presentation now? I guess yes.
No.
Okay, my name is...
Not yet.
my name...
Yeah, now it is.
Yes, my name is Martina Samardzieva, and I will present you a clinical case about hypertrophic obstructive cardiomyopathy. I'll present a 64-year-old man with easy fatigue, shortness of breath, and palpitation with paroxysmal atrial fibrillation, arterial hypertension, no smoker, no alcohol user, family history, mother with...
Martina, we can't
Sorry?
We can't see your slides.
I don't know why.
Slide sharing is not done properly, it seems.
Yes, I share it now. You can see. Can you see it now?
Yes, now.
Now we can.
Yeah,
Okay.
now we can start.
Okay, a 64-year-old man with easy fatigue, as I said, shortness of breath, palpitation, paroxysmal atrial fibrillation, arterial hypertension, no smoker, no alcohol user, family history, mother with arterial hypertension, no history of sudden cardiac death in the family. The therapy at home, patient was at amlodipine, roxaban, rosuvastatin, and metoprolol. By the physical examination we performed, we found a whole systolic murmur at the left sternal border, and other parameters were normal, with normal succus urinalis, normal lungs, clear vascular breathing, vesicular breathing without wheezing, head and neck with no relevant findings. You can see here the ECG. The patient is in sinus rhythm right now with left ventricle hypertrophy on the ECG. We perform laboratory test, and you can see the hepatic function is normal. The renal function is normal with eGFR 69 milliliter. The lipid profile also is almost fine, but we found a very high NT-proBNP, which is a marker for heart failure. We perform echocardiography and we find normal preserved ejection fraction 62% with hypertrophy of the left ventricle with septum 23 millimeters, and we found peak gradient in left ventricle outflow tract 39 millimeter, and we perform Valsalva maneuver. The gradient became 69. We found a global longitudinal strain minus 12.3, and here you can see the gradient. The patient is with mild mitral regurgitation, mild tricuspid, and mild aortic regurgitation. Here you can see the hypertrophy, and maybe you can see very good, but here you can see we found the sum. We made more tests for amyloidosis who are negative, tests for Fabry disease who are also negative, and we recommend genetic tests, but the patient refused. Even that, we recommend a family screening for family members. We calculate the hypertrophic cardiomyopathy sudden cardiac death score, and in our patient it was 2.69 risk of sudden cardiac death at 5 years, and this score shows us that the patient does not have an indication for an implantation of ICD at the moment. And what does the guideline says about the management of this patient, American and European guidelines? As Associate Professor Christova said, echocardiography is the main imaging method to detect hypertrophic cardiomyopathy. 2D transthoracic and Doppler echocardiography are recommended, and rest and during Valsalva maneuver in a sitting and semi-supine position, and then standing if no gradient to provoke LVOT obstruction. Transesophageal echocardiography should be considered in patients with hypertrophic cardiomyopathy and left ventricle outflow tract obstruction if the mechanism of obstruction is unclear on when access the mitral valve apparatus before a septal reduction procedure. And here is the pathway what we should do with our patient. And here you can see when we perform 2D and Doppler echocardiography and rest and with Valsalva maneuver, if the maximum provoke peak gradient is not over 50 and the patient has no symptoms, he is asymptomatic, we repeat echocardiography after 1 year. If the patient is symptomatic, we are going on this pathway. We perform, as we said earlier, stress echocardiography, and if we provoke gradient over 50, we go to LVOT obstruction management. What is the management? If the patient has no symptoms, we perform beta blockers or verapamil. If the patient has symptoms, we start beta blockers. If the patient is still symptomatic or intolerant or contraindication for beta blockers, we start verapamil or diltiazem. And if the patient is still symptomatic, disopyramide or mavacamten are recommended. And if the patient is still symptomatic, the septal reduction therapy is recommended as class 1. We perform angiography, and as you can see, the left coronary artery, left main LAD, circumflex artery, and right coronary artery are without obstruction. We found a big septal branch. Our invasive cardiologist made a manometry test, and after extrasystole, they found a gradient 103. So the diagnosis of hypertrophic obstructive cardiomyopathy was performed. The patient was referred for septal reduction therapy with alcohol septal ablation because there is no other indication for surgery for septal myectomy. we implant a temporary pacemaker through the vena cavity sinistra to right ventricle. And here I can show you the pre-assessment checklist for patient being considered for invasive septal reduction therapy. Here, access alternative for additional explanation for this disease: obesity, respiratory disease, coronary artery disease, anemia, thyroid, arrhythmia, drug side effects, systemic or right ventricle outflow tract obstruction. Access the mechanism of the obstruction with some mid-cavity supporting membrane and other reasons. Access mitral valve anatomy function for probes or other mitral valve abnormalities. And access the distribution and severity of hypertrophy. Minimum anterior septal thickness 15 millimeter. As we said earlier, our patient was with 23. What was the guideline say? For patients with hypertrophic cardiomyopathy who are undergoing alcohol septum ablation, transthoracic and transesophageal echocardiography should be performed during the procedure. It is recommended that SRT be performed by experienced operator working as a part of the multidisciplinary team, and septomiectomy, rather the alcohol septal ablation, is recommended in children with an indication of septal reducing therapy, as well as in adult patients with an indication for reducing therapy and other lesions requiring surgical intervention. Here you can see the picture of coronarography, because I have a problem with the videos and there is no obstruction in this artery. And here you can see how we cannulating the septal branch and how it occluded. And here you can see how the contrast in how contrast look in the angiography, and it's the same at the same moment. The contrast in septum by echocardiography, there is no contrast in the left ventricle. The zone is fine, so there are no contraindication for septal ablation. And the operator inject 1 milliliter alcohol in septal branch, and the manometry, here you can see the manometry after the procedure. The result is very good and the gradients are very low. The patient had no complication after the procedure, and temporary pacemaker was removed after 24 hours. The therapy at discharge was amlodipine, edoxaban, rosuvastatin, metoprolol, empagliflozin for heart failure, and lansoprazole. The follow-up by echocardiography after 3 months, I couldn't find the images, but just the text, and the patient is with the same ejection fraction, but the gradient in the LVOT and after Valsalva are lower than in the beginning. So I think that the procedure is a success, and thank you for your attention.
Thank you, Dr. Samarjeva, for the very nice presentation. And for me, it's a very big pleasure to invite the next speaker, who is Dr. Sharma.
Next, yes, and Dr. Shanmugha Sundaram is a distinguished cardiologist and a gold medalist throughout his academic career, having excelled in MBBS, MD, and DM. He is honored with the Lifetime Achievement Award by the Indian Academy of Echocardiography, as well as Lifetime Achievement Award from the Government of Tamil Nadu, recognizing his outstanding contributions to the field of cardiology. Dr. Shanmugha Sundaram is widely respected as both an excellent clinician and a dedicated teacher. His key areas of interest include establishing one of the largest registries in India, primary pulmonary hypertension, maintaining a comprehensive collection of hypertrophic cardiomyopathy cases. He has also made significant academic contributions through numerous publications in esteemed national and international journals, and has authored several chapters in leading cardiology textbooks. Dr. Shanmugha Sundaram, over to you, please.
Thank you, Dr. Manivasagam. Good evening dear friends. My presentation is going to be on multimodality imaging in arrhythmogenic cardiomyopathy. If you ask me in which type of cardiomyopathy multimodality imaging has more usefulness, I would say without hesitation, it's in arrhythmogenic cardiomyopathy, because imaging has improved our concept regarding this disease process. What was originally considered as congenital dysplasia of the right ventricle turned out to be a cardiomyopathy after realizing that it was an inherited disease with fibropathy replacement of RV myocardium in the younger age group or the middle age group individuals. Then with multimodality imaging, particularly cardiac magnetic resonance, we realized that this cardiomyopathy is not confined to the right ventricle, and it is a biventricular disease. So the terminology has changed to arrhythmogenic cardiomyopathy. One may get isolated or predominant involvement of the right ventricle. Some may get predominant left dominant arrhythmogenic cardiomyopathy, which is relatively a rarer type, and some may have biventricular involvement. If you look at the genes involved, for those with the predominant right ventricular involvement, it is the desmosomal genes. And when you look at the left dominant apical, arrhythmogenic cardiomyopathy, it is the non-desmosomal genes like filamin C, phospholamban, titin, etc. are implicated. I'll just go through some of the cases which I have encountered. 50-year-old female had chest pain, palpitation, had syncope at the house, brought in a state of cardiovascular collapse. ECG on admission revealed VT of LVB morphology, promptly cardioverted, and post-cardioversion ECG revealed a prominent epsilon wave apart from mild ST elevation in V1, V2. So the diagnosis was arrhythmogenic cardiomyopathy. Echocardiogram revealed right ventricular dilatation, particularly the right ventricular outflow tract showed much more pronounced dilatation. The apex was contracting and the free wall was rather hypokinetic. The cardiac magnetic resonance imaging confirmed the presence of delayed enhancement in the right ventricular outflow tract, apart from documenting the outpouchings and microaneurysms. This lady had received an ICD, and she received 2 appropriate shocks for VT, and she went in for progressive right heart failure. She lived for another 12 years. This echocardiogram, where you could see, absolutely no contraction of the right ventricle with gross tricuspid regurgitation. She lived for another 2 years with this clinical status. Next one is again a female who presented with palpitation. And she came to me with a diagnosis of RV volume overload state to consider superior vena cava type of ASD. But one look at the apical four-chamber view, the outpouching confined to the free wall of the right ventricle, marked dilatation of the RVOT gave the diagnosis. Third one, asymptomatic individual with some ECG changes. Again, look at the way in which RVOT is prominently dilated, and the moderator band was hyperrefractile. There was outpouching of the basal right ventricular free wall to confirm the diagnosis. The fourth instance, patient with palpitation, a male, 40-year-old male with ECG changes suggestive of anterior wall ischemia. Echocardiogram, RV showed prominent dilatation. And if you look at the right ventricular apex, it is contracting well, while the free wall was showing hypokinesia. Look at the TAPSE and the free wall strain showed reduction. So, this is an example where this mecanal sign is false positive, not pulmonary embolism. The patient was found to have arrhythmogenic cardiomyopathy. So this is how echocardiography is useful in establishing the diagnosis of arrhythmogenic cardiomyopathy. by documenting RV dilatation, outpouchings, aneurysms, hyperreflective moderator band, reduced free wall strain, etc. And you should suspect arrhythmogenic LV cardiomyopathy in someone who presented with non-dilated hypokinetic LV. It's not only useful in establishing the diagnosis, it also helps in risk stratification. Those patients with marked dilatation of RV and RV outflow tract, those with free wall strain of less than 14%, tell us that they are all these are the people who are predisposed to bad arrhythmic outcomes. Whatever I have shown the garden varieties of arrhythmogenic cardiomyopathy, I'm going to show two more examples where I missed the diagnosis for years together. Patient number 5, 47-year-old female, came in 2005 with atypical chest pain. ECG showed non-specific STT changes. Echo revealed hypokinetic mid and basal inferior wall. Dobutamine stress echo was done, showed some improvement of contraction of inferior wall. Other segments did not show ischemia. She was, she underwent coronary angiogram, which was normal. She was given, medical management as if it was coronary artery disease, possibly like, infarct with normal coronaries. 2 years later, she came back with emotional upset and precordial oppression, ST depression V1 to V4, and she had an episode of pre-syncope also in between. 2016, she again came with progressively worsening dyspnea. This time, LV dysfunction was prominent. Sought the help of MRI, which confirmed the diagnosis of biventricular cardiomyopathy. This is the electrocardiogram where the ECG showed a polyphasic complex in V1. This did not alert me to the possibility of arrhythmogenic cardiomyopathy to start with. The echocardiogram, look at the inferior wall motion abnormalities, which made me to think of coronary artery disease rather than arrhythmogenic cardiomyopathy. The echo done at a later date with RV focused imaging, I could make out the RV apical aneurysm, which I had missed all along for the last 15 years. Cardiac MRI revealed typical findings with enhancement of the RV free wall. The last patient also, I had missed the diagnosis for years together. 45-year-old female, diabetes, systemic hypertension, atypical chest pain and palpitation. Again, regional wall motion abnormality of the infralateral wall. Right bundle branch block with low QRS voltage and T inversion in V3 to V6. Echocardiogram, again, made me to think of ischemic heart disease because of the regional wall motion abnormalities of the inferior lateral wall. But after some time, I realized my mistake, did the echo with the RV focused imaging. Again, I could make out RV apical aneurysm. MRI helped in establishing the diagnosis, RV outpouchings, and the ring-like enhancement involving the infralateral wall and the anterolateral wall. Genetic testing could be done for this lady. She had the plakophilin gene mutation. Her only daughter was screened. Echo ECG was normal. She was negative for the gene. Holter revealed a large ventricular premature contraction burden, so she received an ICD. The last two examples should make us to consider arrhythmogenic cardiomyopathy in anyone who present with non-dilated LV cardiomyopathy with wall motion abnormalities, being confined to the infralateral wall. One other disease which can present like this is sarcoid. I'm sure Dr. Stephen will expand further on this non-dilated LV cardiomyopathy. The so-called triangle of dysplasia of ARVC, now it's shifted. This tricuspid region and the RVOT region of the LV and the LV infralateral or the posterolateral wall. Classically, the disease is supposed to progress through 4 stages: concealed, pre-symptomatic, electrical stage, some abnormalities in the RV, presentation in the form of ventricular tachycardia, then the structural stage where the RV shows progressive dilatation, end up with either RV failure or biventricular failure. Now we realize that there is another phase known as heart phase. People can present with chest pain, elevated troponin, inflammation could be made out with the PET scan. They go in for progressive RV remodeling or LV remodeling with ventricular arrhythmias. So this heart phase could be the way of presentation in the last two patients which I've described, came with chest pain. ECG showed something like ischemic heart disease. I missed the diagnosis, and we should remember that whenever someone comes with typical right ventricular changes, the diagnosis is straightforward with echocardiography. But if someone presents with non-dilated cardiomyopathy, particularly with the regional wall motion abnormalities confined to the infralateral wall, consider this disease. There are so many other diseases which can present with non-dilated LV cardiomyopathy, but do not hesitate to go on for multimodality imaging, particularly cardiac MRI, which can clinch the diagnosis. Thank you.
Thank you very
That
much.
was a nice presentation, Dr. Shammu Sundaram.
Thank you.
Next patient. Professor, because it is Bulgarian, so she should call the next patient and introduce her. Professor Krasimira.
The next presenter, it's coming from Bulgaria. This is Dr. Nikolai Tselov. He will speak about great mimicker of hypertrophic cardiomyopathy or amyloidosis.
Good evening. I'll share my screen just. Good evening.
Yeah, we can see your screen.
You can see your screen and hear me. Okay.
Sure.
Good evening, all. As Professor Christopher said, I will introduce the topic of the great mimicker of hypertrophic cardiomyopathy, which is amyloid heart or primary restrictive cardiomyopathy. Amyloidosis is consisted of the amyloid, which is insoluble fibrary proteins that aggregate and become folded and stick together under certain conditions. The extracellular depositions of fibrils and disruption of architecture reduces the function of the heart, and the cardiomyocyte necrosis, which is in advanced stages of the disease, again, has some structural and functional changes agitating the heart. It is related with myocardial stiffness, which leads to the restrictive cardiomyopathy, right side heart failure, diastolic heart failure, arrhythmias, and usually is related with the poor prognosis. Intercavitary registration and ventricular factor quickly evolve by ICD shocks, which is one case that we can see here. But our first case is of a 54-year-old woman with signs of hypertension, clinical signs of heart failure, which sounds the alarm at first sight. From the echocardiography, we can see the left ventricle hypertrophy, the granular sparkling, the bright echoes. We should note the valve thickness and the atrium thickening and the wax consistence that we can see. From the four-chamber view, we have a view of the normal ejection fraction, the concentric right ventricle, left ventricle wall thickening, which correlates with the normal ejection fraction, even in the presence of congenital heart failure. And we should note the small volumes and diastolic volume. The three-chamber view of this patient, we see the small ventricle chambers, echo images. As we move on to the left ventricle hypertrophy, the discrepancy between the transthoracic echo and the ECG, we should note that there is a combination of the left ventricular posterior wall and the septum with the low voltage ECG patterns that we see, the low voltage QRS complex, and the poor R wave progression in the precordial leads. The mitral inflow and the correlation with the late diastolic velocity, we see the increased peak E to peak A ventricular filling velocity ratio and decrease lateral E wave deceleration time, which is suggestive of the restrictive left ventricle filling. The increased filling pressure and in the left atrium pressure, we see that the atrium functions as a conduit with loss of contractile and reservoir function, and we see that the decrease of systolic and diastolic pulmonary vein peak flow velocity. The hallmark in the setting of wall thickening and infiltration, we can see the reduced mitral annular tissue velocity and the low medium lateral velocity. And those findings are typical for the AL type of amyloidosis and consistent with the diastolic abnormalities. And the two types and two forms of amyloidosis are not morphologically distinguishable. In terms of speckle tracking echocardiography, we do a 2D strain imaging by this technique, in which the strain is equal to the myocardial deformation and the percentage change in length. The myocardium deformation, in this case, we can evaluate to be equal to the systolic function. The reduced global longitudinal strain is a typical pattern in cardiac amyloidosis. The globally diminished longitudinal strain and myocardial deformation, but the apex is still preserved. The ejection fraction might be normal despite those findings. And here you can see the polar plot 2D of our patient with apical segments with better strain, and in comparison, mid and basal segments with lower deformation in respect to the apex. In terms of 2D strain, the peak strain for, we can see here the peak strain for the individual myocardial segments, the strain curves samples that we see, and the characteristic basal to apical gradually impairment of the longitudinal function. Graphically, there are three normal cardiac strains, the three evolutions in times, and here we can see the way the cardiac amyloidosis functions in the cardiac deformation. Echo is still an excellent screening tool to distinguish those types of cases in which cardiac amyloidosis may be present. The strain by speckle tracking echocardiography has gained momentum more recently. And it is regarded to say that we should incorporate global longitudinal strain marking into the cardiac exam. The differences, mainly the cardiac amyloidosis, we can say that the longitudinal function is usually affected before radial function. And moving on to the second case of a 60-year-old man with chest pain and dyspnea, which is slowly progressing in time with hypertension. We see from the ECG the low QRS voltage in the lymph leads. Then from the transthoracic echo, we can see the left atrial dilatation, a small pericardial effusion, and then for moving on to the four-chamber view, we see the bilateral enlargement, the pericardial effusion still being able to see it, and the sparkling myocytes. The diastole has a restrictive pattern that we can see from this image, and the loss of left atrial function with a very small A wave, with almost exclusive diastolic flow, with restrictive filling again, in which the left atrium has a conduit, acts as a conduit with loss of contractile function. Yes. Yeah. The global longitudinal peak systolic strain here in this patient is again reduced with the classical strain patterns, with relatively preserved apical strain with significant basal impairment. Atrial strain is in those cases globally significantly impaired compared to the normal cases, as we can see the left atrial systolic positive peak due to the reservoir function. In terms of the right ventricle, we can assess the increased right ventricle wall thickness with very small cavity size, and the reduced TAPSE, which is again indicative of the reduced right ventricle function. The tricuspid regurgitation velocity measured in this patient speaks of the increased systolic pulmonary artery pressure and the left atrial pressure, which is again increased. And in terms of differentiating cardiac amyloidosis with other causes of concentric left ventricle hypertrophy, we should again set to the septal longitudinal base apex strain gradient combined with the short E-wave deceleration time, and using parametric polar maps of regional longitudinal strain and regional variations in strain as accurate and predictable. In terms of diagnosing and going from suspect to diagnosis and treatment in those patients, in any patients with heart failure, we may suspect a case of cardiac amyloidosis if we have a presence of unexplained and increased left ventricular wall thickness and non-dilated left ventricle. In terms of basic rules to suspicion of those cases, we can say that if the left ventricle wall thickness is over 12 millimeters, and we have one of those listed clinical scenarios, for example, we may suspect such cases. Then we move on to the diagnostic criteria, invasive or non-invasive, in terms of the types that we may suspect, and following the algorithms for diagnosis. And then the treatment could assess both the cardiac complications and comorbidities, and moving to disease-modifying treatment, which is prescribed for cardiac amyloidosis. In general, in cardiac amyloidosis patient treatment, we may refer to the 2023 ACC consensus, which gives us a way of comprehensive and multidisciplinary care for those patients, and following in general the three cases and paths to treating such patients. As you can see, they are all listed here in the ACC consensus. And despite the sophisticated techniques that are available and the rarity that may sound in some regions of the world, Cardiac amyloidosis is still under-recognized, and the cornerstone of successful diagnosis remains in the high clinical suspicion and using the best techniques possible. Thank you very much for your attention.
That was a great presentation, Doctor. Very good. Now we will call upon to the next speaker from Indian Academy, Dr. Suresh Yagaval, who is Senior Professor and Senior Member of Indian Academy of Echocardiography, former Professor and HOD Cardiology Medical Superintendent, Sri Jayadeva Institute of Cardiovascular Science and Research, Bangalore, past President of IAE, and presently working as Consultant Cardiologist, Trinity Hospital, Bangalore, past President of Indian College of Cardiology. Over to you, sir. Yagaval, sir. Please.
Dear friends, good evening to all of you. I will be discussing hypertrabeculated cardiomyopathy. First, I will present you a case, then I will discuss the subject. Here is one of my patients, 53 years old male patient, presented with a history of dyspnea and edema lower limbs. On examination, patient was in congestive cardiac failure, and when we did the echo, this is what we saw. Patient had hypertrabeculated left ventricle. The fourth chamber view shows there is a dilated left ventricle with reduced contractions, and both ventricles are showing the presence of clots. Cardiomyopathy with excessive trabeculation is called as primary genetic cardiomyopathy by American Heart Association, and European Society and WHO calls it as familial or genetic unclassified cardiomyopathy. ETCM, that is hypertrabeculated cardiomyopathy, in prevalences in adults, around 4% of all cardiomyopathy belongs to this group, men more than women, and familial occurrence is seen more frequently. When we do an echo, if we see excessive trabeculation, that itself does not define the presence of cardiomyopathy. Cardiomyopathy is characterized by progressive development of heart failure, ventricular arrhythmia, and sudden cardiac death. This is often associated with the neuromuscular diseases with a genetic substrate. If there is LV dysfunction, the outcome will be adverse. They have compared the prognosis in cardiomyopathy with ET and without ET, and they have observed that there was no difference between the two. Arrhythmias, thrombus formation, LV dysfunction, they are the adverse consequences of ETCM. Number of articles tells that excessive trabeculation is not responsible for any of these complications. Here is one of the patients reported from India, 25 years old female patient, presented with history of palpitation, sweating, dyspnea, and syncope. Heart rate was 200, BP was 80/60. They cardioverted the patient and did the echo, and echo showed hypertrabeculation of the left ventricle, as you see here. Bustier et al., they have followed up this excessive trabeculation patients for 12 months. They have given ARNI in addition to the other guideline-directed therapy, and at the end of 12 months, they observed that at least in some patients, there is a reverse modeling of this LV ET. Up to 1990, we used to call this condition as the spongy pattern of left ventricle. From 1990, we called it as left ventricular non-compaction. And from 2023, excessive trabeculation is a word that is used for this condition. The excessive trabeculation is described at all ages, right from the fetus to the adults, between the incidence being 0.02% to 0.14%. Excessive trabeculations can occur either in isolation or in association with hypertrophy, dilatation, and or reduced daily function, in which case we call it as cardiomyopathy. ET can be a temporary finding and does not always develop into cardiomyopathy. ET is usually asymptomatic. If symptoms are present, it will be specific to the type of the underlying cardiomyopathy. If there is a family history of excessive trabeculation, then probably there is genetic predisposition. We all use echo to diagnose excessive trabeculations, and here we use Gini criteria. There should be presence of two-layer myocardium, The ratio of trabecular to compact myocardium should be more than 2:1, measured in the end systole in the short axis view. The typical location of most pronounced trabeculations is in the mid-lateral, apical, and mid-inferior segment, and the absence of coexisting cardiac abnormalities is presumed. This is the normal area. This is the hypertrabeculate area, compact layer, and trabeculate layer. This is how they measure it. If the image quality is not good, then we can use contrast, and that will show you the presence of trabeculations and deep recesses. 3D echo also helps in diagnosis of excessive trabeculations. Color flow also shows the entry of the color into the deep recesses in the presence of hypertrabeculated left ventricle. CMR, cardiac magnetic resonance imaging, has a greater contrast resolution and blood metal differentiation, allowing better visualization of the trabeculations. Here we use Peterson's criteria. The ratio of trabecular to compact myocardium should be more than 2.3 at end diastole in the long axis view. These are the horizontal and vertical long axis view where you are seeing the excessive trabeculations. Cardiac computed tomography and invasive ventriculography can also visualize LVET, but it is not generally used. There are no generally accepted morphological diagnostic criteria for these techniques. Here is an image of cardiac CT with contrast. One can see the excessive trabeculations. De Silva et al. They have studied the intrauterine fetus, and at 5 weeks, this is the compact layer which is thin, this is the trabecular layer, and at 7 weeks, this has thickened, this also has thickened, increased in size. At 21 weeks, you can see the compact layer is very much thickened, but not at the expense of trabecular layer. Thus, the author feels non-compaction is a misnomer. Both trabecular and the compact myocardial layers grow many-fold during development, but not always in equal proportion. That is called as allometric growth. Earlier notion suggesting the compact layer is formed as a result of compaction of pre-existing trabeculations. Currently, there is no evidence for that. Excessive trabeculations have been observed in some normal individuals, neurovascular diseases, pregnancy, athletes, hematological disorders, renal disorders, cardiomyopathy, and other genetic and metabolic disorders. ET and pregnancy. The hemodynamic overload in pregnancy, it can cause excessive trabeculations in some individuals. More often, it has been observed in African Americans. Possibly, there is a genetic susceptibility. This ET regresses promptly after delivery, usually by 3 months. ET in children has been observed in some normal individuals as a normal variation or as a complex, in association with complex congenital heart diseases like Epstein's anomaly. However, more details, more studies are required to study about the ET in children. ET in athletes. The prevalence is 1 to 10% among competitive athletes. If there is a normal LV function, no adverse cardiac events, then there is no need for further investigation. The candidate can continue athletics. ET is of concern if there is a systolic dysfunction or dilatation or a cardiac symptom or abnormal ECG is present, and these people need more follow-up and management. ET is likely to be the expression of adaptive remodeling. Giuseppe et al. They have screened participants of the Olympic Games from 2012 to 2022, and they observed ET in 1,492 individuals, which forms 29%. And they observed that individuals who are participating in the weightlifting, wrestling, judo, athletics, or in the endurance group, cycling, rowing, cross country, these are the people who show excessive trabeculation more frequently than skills like archery, golf, shooting, where the incidence is less. ET may cause clinical concern in athletes. ET is an expression of adaptive remodeling. In the absence of alert criteria, there is no negative value for this excessive trabeculations. ET has been described in thalassemia, chemotherapy-related cardiac dysfunction, and hemoglobinopathies. ET has no independent prognostic significance. LISA study followed the asymptomatic ET individuals for 10 years, and it showed neither the presence nor the extent of trabeculation was associated with adverse cardiac remodeling or fibrosis. Treatment: if patient is asymptomatic, excessive trabeculations need no treatment. For others, if they are symptomatic, so medications according to the symptoms. In some cases, implantable devices or surgery may be required. Family screening is recommended, especially in pediatric patients. Just summarizing, excessive trabeculations is described at all ages. Current evidence do not support the formation of non-compaction. ET is observed in healthy individuals and in pregnancy, athletes, and with cardiac diseases, inherited or acquired or congenital in origin. Asymptomatic adults with excessive trabeculations need no further follow-up. Cardiomyopathy with ET are managed by symptoms rather than the trabecular pattern. In neonates and children, caution is warranted because of the association of genetic and neuromuscular disorders. Thank you.
That was a nice presentation, sir.
Thank you very much for the nice presentation. I would like to introduce the next speaker from Bulgaria. This is the Dr. Stefan Dimov, and he will be presented for non-dilated cardiomyopathy clinical case.
Can you remove your slides, Dr. Yavagal?
Yagaval, stop sharing, you please.
Yeah.
Hello, everyone.
Just share your slides.
Yeah.
Do you see the slide? Okay, so my name is Stefan Dimov, and I'll be talking about hypokinetic non-dilated cardiomyopathy. So let's start with a quick definition. What is HNDC? It's a relatively newly recognized form of cardiomyopathy. It combines features of impaired heart muscle function without the classic dilation of the left ventricle, which is typical for dilated cardiomyopathy. And it has very nuanced symptoms and is recognized as an early form of systolic heart failure. So it's characterized by left ventricular systolic dysfunction with an ejection fraction below 45–50%. So no significant LV dilation or only mildly increased LV size, and no significant secondary causes for the increased LV size, like hypertension, coronary artery disease, or some valvular disease. Some studies show that it may represent as an early form of dilated cardiomyopathy, but it's still quite, they're still quite uncertain about that. So the risk factors and etiology. First of all, genetic mutations, for example, in the TTN gene, LMNA genes, and others. Also some toxins like alcohol or chemotherapy, inflammatory causes like myocarditis after viral infections, of course idiopathic when we're not really sure what causes the disease, and very often familial like diseases or mutations, which require further genetic screening. The clinical features are often very subtle, very ambiguous. So we see a normal heart size on an X-ray. We are less likely to see severe heart failure symptoms. The ECG often shows arrhythmias or conduction blocks. We have higher ejection fraction and lower anti-pro BNP levels than the classic DCM. So when we compare it to classic DCM, there's a 2023 study published in the Journal of the American College of Cardiology. They compared the 1-year outcomes between patients with HNDC and those with idiopathic dilated cardiomyopathy. And it shows that they have the patients with HNDC have higher baseline ejection fraction of the left ventricle, lower pro-BNP levels, and no hospitalizations compared to the DCM groups. That's in the window of 1 year after the diagnosis. So other type of cardiomyopathy is non-dilated left ventricular cardiomyopathy, which some authors say is very comparable to the HNDC. It's a non-ischemic, we see a non-ischemic LV scarring or fatty replacement on the CMR, and isolated global left ventricular hypokinesia without scarring, so without any signs of ischemia. And this is some of the CMR images compared to gene mutations. So we see the DST gene, the LMNA mutation, and the CTM, for example. So the diagnostic approach for hypokinetic non-dilated cardiomyopathy, of course, we should start with echocardiography, and we'll see low ejection fraction and normal left ventricle size. The cardiac MRI would often show fibrosis with late gadolinium enhancement and preserved perfusion. Genetic testing is the key when it comes to diagnosis and also family screening. And echocardiography should also exclude valvular causes, and we should also exclude from the examination ischemic or hypertensive causes. These are the ESC recommendations when it comes to cardiomyopathies. This is from their 2023 guidelines. So we should do a comprehensive evaluation of cardiac dimensions and left ventricular and right ventricular systolic function. And that's with the echo. And then with the CMR, the first recommendation is the class 1A is contrast enhanced CMR with patients with cardiomyopathy at the initial evaluation, and then at later stages of the progression of the disease, we should consider the contrast enhanced CMRs during the follow-up to monitor the disease progression and to see what the risk is. So this is a quick comparison between HNDC and classical DCM. So the ejection fraction is reduced in both. The left ventricular size is normal or mildly bigger in HNDC, and it's significantly increased in DCM. Symptoms are often milder in HNDC, so people tend to feel better. Fibrosis, though, is present in both conditions, and the prognosis is still very variable and uncertain in HNDC because it's a newly dangerous condition, and it's often very worse in DCM. Now, the clinical case that I will present today is a 51-year-old woman with complaints of heart palpitations in the last 2 to 3 months. She had surgical intervention due to breast cancer in 2015, and she underwent hormonal therapy, no chemotherapy. She has Hashimoto's thyroiditis and hypertension since 2005. She's currently on bisoprolol, lisinopril, amlodipine combination medicament, and levothyroxine for her thyroiditis. So this is our first image. We can see the global hypokinesia and the reduced ejection fraction even from this initial view. This is an epical view, and if you look closely, we can see some apical hypertrophy, which was measured at around 20 millimeters. This is the so-called fish mouth view, still the hypokinesia, which is global. We can see the valvular apparatus here, the mitral valve. And here we can see some fibrosis on the mitral valve and the aortic valve. This is her EPA ratio. She has a mild mitral regurgitation and her E to E prime ratio also. So after the first examination, the first time the patient visited our clinic, she had a global longitudinal strain of -9.2, which was quite low. You can see it here in the other segment. After this first examination, the next step was to address the palpitations, like her symptoms that she came for in the clinic. So she had a solitary ECG for 24 hours, and the results were or sinus rhythm with 55 BPM on average, no registered episodes of AFib or atrial flutter. She had a singular episode of tachycardia, 2 or 3 instances of singular PACs, and very common singular PVCs with 2 distinct morphologies during the day and during the night. There were also in episodes of Hegemony and polymorphic coupling. So that would explain her palpitation symptoms. After the hotel ECG, she was referred to another clinic to do a CMR study. Unfortunately, I don't have the images because this was a third-party center. So the doctor there saw the things that we saw on the echo, a non-compaction of the LV apex with reduced systolic function, and the non-compact to compact myocardium ratio of 1.56. She had diffuse left ventricle hypokinesis with reduced relaxation. The ejection fraction in our exam was around 44%. According to the CMR study, it was more like 46. The diastolic volume and the systolic volume was as follows: 136 to 73. The right ventricle ejection fraction was within normal limits, and the colleagues suggested that the CMR criteria for non-compaction cardiomyopathy of the left ventricle weren't met. So that's not, it didn't explain the things that we saw in the apex of the left ventricle. So after the CMR, the management of hypokinetic non-dilated cardiomyopathy is it follows standard heart failure with reduced ejection fraction guidelines. So ACE inhibitors or ARBs or ARNI, beta blockers, SGLT2 inhibitors, diuretics is needed, device therapy, and also family screening if there's any hereditary etiology. So the patient was started on additional 10 milligrams of lisinopril in the evening, dapagliflozin, coenzyme Q10, and magnesium. So from top left to the bottom right, these are her successive examinations in our clinic. So as you can see, the last one was of the 16th of May this month, and it's in the bottom right. So as you can see, her ejection fraction is like it's lower, but we could sustain the percentage, so it didn't drop. And her global longitudinal strain was increased. So as of 5 days ago, she's feeling well, no palpitations, no tiredness, no symptoms of any disease. The advanced management in patients who wouldn't take well after only medication therapy is, of course, genetic counseling and testing to see if there's any genetic cause for the disease. ICD, of course, for lower ejection fractions or people with sudden cardiac death history in the family. Of course, the CMR surveillance throughout the disease process. And the lifestyle changes for any cardiac disease, alcohol and salt restrictions, and exercise, of course, in moderation. So the key takeaways from this case are that the hypokinetic non-dilated cardiomyopathy is a cardiomyopathy with reduced ejection fraction without left ventricular dilation. We can detect it early when we use imaging like echo and genetics, of course. The standard HFrEF therapy applies, so nothing special there. And the prognosis depends on the fibrosis of the myocardium and the genetics of the person. And the researchers think that the genotype guided care is the future of treating this condition. So yeah, thank you very much.
That was a nice lecture indeed. Now we will go to from our Indian Society, echocardiographic faculties. Next, Dr. Vinayak Agrawal, Senior Director and Head Clinical Cardiology and Advanced Cardiac Imaging, Fortis Memorial and Research Institute, Gurugram. Awarded with the FACC, FASC, and the FAHA, keen interest in heart valve, structural heart disease program, and pulmonary hypertension. He is a co-investigator in Miracle EF, Improve IT, ACA, Solid TIMI 52, and PALAS and Phase 2 trials. International study of UT 15C in pulmonary arterial hypertension, and course director of annual Echo Delhi conferences and conduct regular cardiology lectures and workshops in ECG, echo, and transesophageal echo and advanced echo programs is involved. Over to you, sir, Vinayak, sir.
Thank you, sir. So first of all, I'd like to thank my seniors and organizers for this unique opportunity. And my topic is unique as well because it is about reversible cardiomyopathies. I'm going to just show you a few cases highlighting the spectrum of reversible cardiomyopathies. Now, broadly, you can actually divide them into various types. And first, very commonly seen is the tachycardiomyopathies, which can be because of AF, atrial fibrillation, or flutter with forced ventricular rate, very frequent ventricular ectopics, which can produce cardiomyopathies. It can be peripartum cardiomyopathy, autoimmune mediated, like in SLE or sarcoidosis.
I'll see your slides.
It can be HIV, myocarditis, septic shock mediated, and very commonly seen Takotsubo cardiomyopathy, which is basically a sympathoexcitation and autonomic dysfunction with some changes nowadays, which we're seeing in pathophysiology. Then, of course, metabolic like thyroid and parathyroid diseases.
I'll see your slides.
Your slides are not seen.
Oh.
Share screen.
I have shared it actually.
Has the previous speaker removed his slides? But your slides are not seen.
Just 1 second. When I shared, it was there. I mean, I'm surprised that it hasn't. Okay, let me share again.
Your icon is active.
Are you seeing them now?
No,
Not yet.
Now?
no.
No.
Okay, I think what I'll do is just please go on to the next speaker. I will just rectify this and then come back.
So, Dr. Kannan, are you ready?
BRJ, Dr. BRJ
Yes, sir.
Kannan.
Yes, sir. I am ready.
Right. Next, we'll go to Dr. BRJ Kannan. He did his cardiology at Sri Chitra Tirunal Institute of Technology at Trivandrum, fellowship in pediatric cardiology at Amirda Institute of Medical Sciences, Commonwealth Fellowship in Interventional Cardiology at St. Thomas Trust London Hospital. Current position is Director and Senior Interventional Cardiologist, Vadamalayan Hospital, Madurai. Original publications are more than 30. Chapters written in books more than 12. Academic lectures delivered more than 300. Proctor in various cardiac interventional procedures. Over to you, BRJ Kannan. He is a famous pediatric cardiologist in south part of South India.
Thank you, sir. So he was very specific. He told south part of South India. Okay. Anyway, sincere thanks to everyone who have given me this opportunity. So my topic is hypertrophic cardiomyopathy in children. Just some time back, Dr. Agarwal was trying to talk on reversible cardiomyopathy in children, especially in less than 4 or 5 months old children. One very important reversible cardiomyopathy is diagnosing ALCAPA, anomalous origin of left coronary artery from pulmonary artery. We have got several experiences. Even up to 2 years, they present as dilated cardiomyopathy. Of course, tachycardiomyopathy is also common in children. Now, let's come to this topic of hypertrophic cardiomyopathy in children. So, pediatric HCM is a large heterogeneous group of disorders. As you know, the common ones which are associated with mutations in sarcomeric genes are called primary HCM. The non-sarcomeric gene causing HCM are called secondary HCM. So in adults, we do know we have some criteria of more than 12 millimeter or more than 15 millimeter in diastole. Here, when the LV wall thickness is more than 2 standard deviations from the predicted mean in the children, with a positive family history, it is called diagnosed to have LVH. And if it is more than 2.5 in those without the particular history. So in less than 1 year old, the sarcomeric cause of HCM forms only 17%. All the other rest, say nearly 70% will have some or other secondary causes. So in glycogen storage disorders, Pompe disease is very common. We do have come across some case of Pompe disease. In the malformation syndromes, of course, Noonan syndrome, most of us would have seen some or other Noonan syndrome. Of course, we have lysosomal storage disorders, mitochondrial disorders, fatty acid oxidation disorders, and endocrine disorders. Among the endocrine disorders, one thing is extremely common. I don't know whether we can call that as hypertrophic cardiomyopathy. That is, infant of diabetic mothers will have transient hypertrophy of both right ventricle and left ventricle, especially left ventricle. That will be an incidental finding. The echo will be done for some other reason because of some murmur or to see whether there is a PDA because of some clinical indications or not. This hypertrophy regresses over a period of 4 to 6 months. So one reversible form of hypertrophic cardiomyopathy in the newborn is in those children who are born to diabetic mothers, so infant of diabetic mothers. So this is less than 1 year old. This is what the percentage of causes for hypertrophic cardiomyopathy. In beyond 1 year, see the specific causes still are there, is about 15%, whereas majority, 60% will have some or other genes identified in the sarcomeric regions. And without any gene identification, idiopathic hypertrophic cardiomyopathy forms 25%. So this is a 3-month-old child referred to us as hypertrophic cardiomyopathy. This was way back when I was at Amrita Institute of Medical Sciences. And this ECG is very, very classical of this condition. You can see very tall QRS complexes which we generally see in many hypertrophic cardiomyopathy, but this is unusually tall. And also there is a very short PR interval. So the short PR interval associated with unusually tall QRS is very classical of Pompey's disease. So this is the echocardiogram of the Pompey's patient. Unfortunately, I don't have the running image. And this will exactly look like any common hypertrophic cardiomyopathy. But what will be the clue? In most of these secondary hypertrophic cardiomyopathies, these are infiltrations into the myocardium, and they all will have LV dysfunction. So in general, we do know patients with hypertrophic cardiomyopathy will have normal LV function, or even they appear hypercontractile. On the other hand, if you see LV dysfunction with the background of hypertrophic cardiomyopathy, we should always think of some other secondary cause, and this is an example of infantile Pompey's disease. In general, these patients have very poor outcome. It's because of the deficiency of alpha-glucosidase enzyme. They present as cardiomyopathy, muscle weakness, hypotonia, and respiratory disorders. They can present in adulthood, adolescent, or infancy. The infantile presentation has a very bad prognosis. And if untreated, 90% die by 1 year. We do have this recombinant human alpha-glucosidase enzyme as the replacement. This is effective regardless of the patient. And this patient, when I saw some 15 years back, this enzyme was extremely costly. One dose was costing about 2.5 lakhs. And we tried to help, but the patients couldn't afford, and we lost that particular child. And the second one, which is not uncommon, is the Noonan syndrome-related hypertrophic cardiomyopathy. So HCM affects 20 to 30% case of Noonan syndrome. They often present early in the life, the median age of around 5 months. Biventricular HCM is very common in patients with Noonan syndrome. And there will be varying degrees of right ventricular outflow tract obstruction, as we commonly see in left ventricular outflow tract obstruction in LV normal. We do have RVOTO in these children with Noonan syndrome. The 1-year survival rate is about 34%. Recently, we do have some drugs like trametinib, which is a MEK inhibitor. Frankly speaking, I don't know what is MEK inhibitor. These are the drugs which have been found to be effective in patients with Noonan syndrome. So I think I have some 4-5 cases in the follow-up. To be very frank, I have not kind of properly followed up. I do have seen 4 patients of Noonan syndrome with biventricular non-hypertrophic cardiomyopathy. This case I got in the as a case report, JACC case report, where because of the RVOT obstruction, they have done the stenting of the RVOT. You can see the stent here. And this significant LV hypertrophy in patients with Noonan syndrome has regressed following this MEK inhibition therapy. This is probably a new treatment available for patients with Noonan syndrome. Now, what about HCM beyond 1 year? So among the children of less than 18 years diagnosed with HCM, the median age at which the diagnosis was made is 7 years. 1/3 diagnosed before 1 year. As we all know, autosomal dominant inheritance with the variable penetrance and variable expression is the usual way of inheritance. Males have more prediction beyond 1 year, and overall mortality is quite low, around less than 1% per year. So the overall outcome is quite good, even in children diagnosed with hypertrophic cardiomyopathy of usual sarcomeric type. So with this background, we'll go to this current case. This boy is currently 17 years old. Non-consanguineous parents, father is an endocrinologist, mother is a gynecologist. The child was born at Liverpool, United Kingdom. It was a cesarean section delivery for fetal distress. Child needed ICU care and was found to have dilated cardiomyopathy. So all the workup done for dilated cardiomyopathy in the newborn period were negative. Child improved to some extent, was discharged, but again subsequently needed further intermittent ICU admissions for inotropic support. And cardiac transplantation was offered in view of persistent heart failure. Parents decided against it and returned to India. Obviously, they were mentally willing to kind of prepare to settle in UK because of the child, and because they wanted to have family support in the treatment of the child. They came to India and they came to us. So child was re-evaluated at our center at Madurai. No evidence of Alcapa or tachycardiomyopathy was seen. Our echo at the time of presentation, around 7 or 8 months, I think, the LV thickness was preserved in the areas of non-compaction near the apex. So a diagnosis of probable non-compaction LV was made at that time. Like right now, we will relabel as excessive trabeculation related cardiomyopathy. and started on the usual medications, beta blockers, diuretics, ACE inhibitors. Dramatic recovery was noticed in the next 3 months, 3 to 4 months. At the age of 18 months, the LV function was normal. The medications were tapered and stopped for a year. Thereafter, he had normal growth and participated in all the sports without any symptom. Early echo screening was done. He remained well, and we stopped doing echo screening at the age of 10. Thereafter, practically, we kind of, forgot this child. Even the parents forgot about the illness of the child. Very recently, now at 17 years old, he had allergic bronchitis. And incidentally, when we did the echo, it revealed hypertrophic cardiomyopathy, very, very classical. Okay. So this is his recent echo showing uniform involvement of all the areas of the ventricle, hypertrophic cardiomyopathy. There was no evidence of LV outflow obstruction. So this is a short axis, as you can see. Septum is more involved in other areas, which is a very common finding. And there was no outflow obstruction. This is the reading of the M mode. And you can see the left ventricular dimensions are kind of, very, very high, more than 20 millimeters. And there is no LVOTO. So lab studies. As we know, there is no specific testing to diagnose HCM. It is mainly aimed to rule out secondary causes in infancy. So that had been already done. But at the time, he presented as DCM. Right now, what we need to do is a genetic testing for sarcomeric genes. So at least 15 different genes have been identified to cause HCM. They are in 6 chromosomes. More than 400 different predominantly missense mutations have been discovered. These genes encode for sarcometic proteins such as myosin heavy chain, actin, titin, myosin binding protein, tropomyosin, etc. So 60% of HCM in children carry some or other mutations. So we performed the gene analysis for this child, and it came out to be homozygote for the ALPK3 gene. So exactly, it's a very rare gene to be identified in patients with HCM, and that too in the homozygote form. This boy was homozygote for ALPK3 gene. Okay, and this was in exon 6, and this is a known gene variant, but was autosomal recessive, and it's a relatively rarer form of the gene. And because it is a homozygous variant, we screened the children, mothers, my father and the mother for any cardiac illness, but their echo was normal. No other sibling for screening. So based on this gene, I mean, we were not much better off, but anyway, there is some gene anomaly of the sarcomere. So he falls in the usual variety of sarcomeric variant of the HCM. So what about the role of cardiac MRI in HCM? So MRI is an important adjunct in the evaluation of anatomy and outward obstruction, especially if the echo is poor. It also tells us late gadolinium enhancement, which are areas of fibrosis, which tell us about the probable turning into DCM further later or the risk of arrhythmias. So it helps in the risk stratification of sudden cardiac death. So this is the MRI of this boy. So you can see the uniform thickness, the apex is slightly spared, but there is a definite involvement. There is no LGE, and there is no other unusual finding in the MRI. So this cardiac MRI was, these are the various thicknesses, and the maximum thickness recorded was 26, which is very high. So what about the risk of sudden cardiac death in patients with HCM, even in children? So the sudden cardiac death is the most devastating presentation. That could be the first clinical presentation of the disease. The highest incidence is seen in pre-adolescent and adolescent children. This boy just crossed the adolescent period. Fortunately, it didn't present in the pre-adolescent or adolescent period. Typically occurs with vigorous sports. History of pre-syncope or syncope identifies these children who probably warrant urgent evaluation and treatment. The degree of LV outward obstruction has not been shown to be a risk factor for sudden death. This is a very important point. So the sudden death is due to arrhythmia, and it has no clear correlation with the LV outflow obstruction. And the degree of LV outflow obstruction has no clear correlation with the symptoms. So if there are significant symptoms on LV outflow obstruction, then we have to treat the LV outflow obstruction. Otherwise, even treating LV outflow obstruction without any symptom has not shown to be prognostically modifying the disease. So this boy doesn't have any such history, but we are always worried. That's the only worry, if at all, because overall the outcome is as good as in adults, but the worry is always there. So we performed Holter monitoring, which is negative. We have done twice. There is no arrhythmia. So what is the indication for AACD in these children? If there is documented arrhythmia, aborted sudden death, malignant genotype, strong family history, all these things are negative in our child. So when you put in the usual indicators, the sudden cardiac death risk was 3.5% in 5 years, and there is no indication for AACD as of now. So this boy is currently on bisoprolol 5 mg daily due to inappropriate sinus tachycardia, and also to help these children from developing into any diastolic dysfunction-related symptoms. He is claimed to be asymptomatic, but obviously we have restricted the physical activities. We have planned to do yearly echo and MRI subsequently to see the progress. Okay. So thank you for the patient listening. Thank you.
As usual, excellent presentation, BRJ. Thank you very much. Now we will go to Vinayak. Please go ahead, sir.
Thank you. So I'm going to present on a very unique cardiomyopathy, which is a reversible type. And the various types of reversible cardiomyopathy can be, probably listed as tachycardiomyopathies like post atrial fibrillation or flutter with fast ventricular rates, after VTs, after very frequent VPCs. It can be peripartum, it can be after inflammation or infections like HIV, myocarditis, septic shock induced or sepsis induced, and even in sarcoidosis or SLE, connective tissue disorders. It can be metabolic like thyroid and parathyroid diseases. Sympathetic excitation like Takotsubo, which is actually the commonest one which we see in our clinical practice, and also the chronic diseases like uremia, obesity, and cirrhotic cardiomyopathies. Now, I'm going to show you a few cases. So this was a 25-year-old gentleman who came to our emergency with a road traffic accident, put on ventilator with severe cerebral contusions, and was obtunded. He was initially extremely agitated with severe tachycardia and hypotension. So the patient was started on adrenaline, noradrenaline resuscitated with fluids. And ECG was this, initial ECG was this. You can see widespread STT changes, ST elevations in all the leads. Patient was quite sick. And this was in the emergency, the echo, which was done with very poor acoustic window. You can see that there is, not much seen. So we decided to go for a contrast echo. And that's where we could pick up the apical ballooning in this patient. And this was actually a case of stress cardiomyopathy. And these patients sometimes develop the LVOT obstruction, severe mitral regurgitation, and shock. And in these patients, sometimes, you need, the advanced circulatory support, mechanical circulatory support, or MCS. And after recovery, patient recovered quite well. The ECG normalized, and this was the echo where you can see that the pumping was normal. The case 2 is a patient who was 45-year-old male who was sent to us with chest pain, classical inguinal chest pain with ST depression in anterior leads. Troponins were mildly raised. However, the angiography was normal. So he fitted into what was known as the Minoka subset. And when we did the echo, you can see that initially the echo showed mid-anterior septum was hypokinetic at this point here. And we also did a contrast, and you can see this mid-anterior septum and posterior septum were hypokinetic, in fact, akinetic, bulging out. So this is typically what is known as the mid-ventricular Takotsubo cardiomyopathy, or the Hawks beak appearance, which is typically Hawks B appearance even on a left ventriculogram. And this is a typical presentation of a mid-ventricular Takotsubo cardiomyopathy. And after recovery, you can see that the patient completely recovered. There was no wall motion abnormality. The case 3 is a 67-year-old lady, and this basically tells you about the complexity of the stress cardiomyopathies or reversible cardiomyopathies. She was a diabetic, hypertensive with severe triple vessel disease, but on medical therapy, had an underlying CKD, was on hemodialysis, and had been inserted with the permacath. She came to us with septic shock. See, ECG showed non-specific STD changes. The troponins were mildly raised, but NT-proBNP was very severely raised at 87,000. And this is the picture. You can see that the anterior septum is hypokinetic. The left ventricle is dilated. There is apical ballooning at this point. And there is also large pericardial effusion. Now, if you look at the, this was a typical Takotsubo cardiomyopathy because she eventually, we have to remember that some of the Takotsubo cardiomyopathies can also appear in the background of triple vessel disease. But here the wall motion abnormality was out of proportion to the ECG changes, the troponins, and the the regional wall motion abnormalities as well. So another feature which we saw was the CRAT, or the catheter-related right atrial thrombus, which you can clearly see here, large pericardial effusion with tamponade features. And you can understand the complexity of the case with Takotsubo cardiomyopathy as well. This is another case presenting to us with fever and chills, had bilateral pneumonia, and a patient was quite sick. The blood pressure was on the lower side, TLCs were raised, and HRCT chest showed bilateral pleural effusions, consolidations bilaterally, and ground glass appearances. And there was also pericardial effusion. And this was tachycardia, sinus tachycardia on ECG. This was the chest X-ray with consolidations. And this was the echo, which you can clearly see that there was large pericardial effusion, and patient was in tamponade and was quite sick. So he had to undergo pericardiocentesis to remove this fluid and stabilize. However, after 2 days, he suddenly deteriorated. And you can see here that the right ventricular RVOT is dilated. This is the inflow view. The entire right ventricle is hypokinetic with severe low pressure TR, with high pressure TR of around 52 millimeters of mercury. And this was the 4-chamber view where you can clearly see that the right ventricular apex is hypokinetic and dilated. So this was a case of RV cardiomyopathy, Takotsubo cardiomyopathy of the right ventricle. And this IVC was dilated as well. So, and there can be 2 variants. One can be a basal variant, which is rare, but this was an apical variant. And the Takotsubo cardiomyopathy can be of various types. It can be apical ballooning, which I showed you, can be basal, midventricular, and sometimes very, very focal. So there are various types, and biventricular cardiomyopathies are also quite common, about 17 to 25%. RV cardiomyopathy, on the other hand, is relatively rare. What is interesting to note is this is a very recent article. There is a shift in the paradigm of Takotsubo cardiomyopathy with almost 28% of the patients now have midventricular type of cardiomyopathies. And there are some very atypical features even in physical triggers are seen in about 60%. It is a highly heterogeneous population, nearly 71% mean age. This is Western data. We see it pretty much in the younger age group as well. And there is also higher prevalence in males in about 15% as compared to what was thought that it is more common in women. There is another interesting aspect is the CMD, the microcirculatory dysfunction, which is now supposed to be one of the mechanistic pathways other than inflammation, metabolic dysregulation, and neuroanatomical substrates. So it is not benign. 7% overall mortality, with nearly 25% presenting with QT prolongation and ventricular arrhythmias, and about 15% presenting with cardiogenic shock. So there is a definite changing paradigm of Takotsubo cardiomyopathies. The last, which I'm going to show you, is a case of CA colon who was given 5-fluorouracil or Folfox for the treatment, and the patient suddenly deteriorated. There were some ECG changes with T inversion and slight ST elevations. And you can see here again that the patient had the dilatation of the left ventricular hypokinesia, especially of the apex, but the entire left ventricle was dilated and hypokinetic. The patient, you can see, is there was actually depressed E prime and E ratios. The LV end diastolic pressures, LV filling pressures were raised. the GLS was markedly reduced to around just minus 10%, and the EF fell from normal to around 35%. So this was the classical case of cancer therapy-related cardiac dysfunction. And after managing these patients with supportive therapy, the ECGs improved, the patient's ejection fraction improved significantly, and you can see that the left ventricle has completely recovered. And the GLS also improved to about 12%, which eventually became normal after a few months. So this was a classical case of CRCD or CTR CVT, as we call it. And the way to diagnose that is to look for any decrease in the ejection fraction of more than 10 percentage points in EF, or more than 15% decrease in the GLS from the baseline, including increase in the cardiac biomarkers like troponin and NT-proBNP. So the GLS is coming up in a big way in cardio-oncology, not only for diagnosing cardiotoxicity, but also in other areas of hemato-oncology, immunotherapy, radiotherapy, and we are also looking at the RV cardiomyopathies in these cases, where a fall in GLS of more than 15% is considered significant. So with that, thank you very much, and open to questions. Thank you.
Thank you very much, sir. It was an excellent presentation. Now we will go to the question and answer session. In between, if one of us, if you have got any clarification or questions, first we will clarify that. Then we will go to the audience. From the audience, if I ask, only few questions raised, only 3 questions raised. Already it was answered by Professor Ristova. That is Valsalva maneuver. Dr. Shanmusundaram was explaining that. Can you please explain Valsalva maneuver, number 1 question? Number 2 is whether the LV thickness should be 15 or 13. There was a question. Again, Dr. Shanmusundaram, could you clarify that?
I think that,
you have already answered, it seems.
I've done that, but it's better she answers that. Dr.
Ristova.
Okay.
Ristova is there?
Overshot the time, so probably.
Yeah.
They would have left, it seems.
Yeah. So probably you can just brief it, because people are watching us on YouTube and may not have access to all the question answers.
Only 2 questions. That's all.
15 millimeter is the standard criterion for diagnosing HCM, but one can use 13 millimeter cutoff when you do family screening of probants with proven disease. Then, if you have other features of hypertrophic cardiomyopathy, for example, if there is a dynamic obstruction, or if there are abnormal phenotypic features like long mitral leaflets or septal bands, you can consider 13 millimeter as the cutoff. Valsalva is not the best way to induce gradient. Exercise is the best way to induce gradients. But for practical purposes, we do Valsalva in the echo lab. What I generally do is ask the patient to take a deep breath. I press the abdominal wall and I ask him to push my hand out. Majority of the time it works. This is one of the ways of asking a person to do a Valsalva maneuver.
Then one more question is, RV arrhythmogenic cardiomyopathy from RV infarct.
I think that he has answered, I think.
Again, this is propping up in the question and answer.
Sir, like Dr. Simi has mentioned, people who are watching YouTube may not be, seeing this. Let me answer that very briefly. Clinical presentation is going to be very typical in RVMI. Though isolated RVMI is known to happen, majority of the time it occurs along with inferior MI with classical symptoms as well as ECG presentation. But if you are given only the echocardiography, I generally look at the RVOT dilatation. If RVOT is predominantly or disproportionately dilated, I tend to think in terms of arrhythmogenic RV cardiomyopathy. because in RVMI, generally there is a global hypokinesis. Another one is focal outpouchings or the RV free wall does not occur in RVMI. It occurs only in arrhythmogenic cardiomyopathy.
Thank you very much. If
Thank
there
you.
are no questions, can we wind up
Yes,
this
sir.
session?
We can log off. Yeah, we've already overshot time.
Yeah.
But the presentations were wonderful and all the speakers have done a good job. Thank you so much for sparing out your time to all my dear seniors and colleagues. Good night, sir.
Good night. Good night,
Good night,
everyone.
sir.
Good night.
Signing
sir.
off. Bye-bye.
Thank you very much. Good night.
Good night.
Good night.
Bye-bye.
Good night. Thank you very much.
Yeah.
Bye-bye.
Thank you. It was wonderful listening to all of you. Thank you.